It's my pleasure to introduce Professor David Rees, who's a hematologist, professor in hematology with a special interest in sickle cell disease at King's College. And he's the consultant of the British Sickle Cell Society, has several publications in the field of sickle cell, and has been involved in most of the clinical trials involving sickle cell. And the presentation is on the pathophysiology with a focus on clinical implications.
Thank you. So I'm going to do the pathophysiology in 10 minutes. It will be quite brief. My disclosures are these. We've already seen this slide. I kind of disagree slightly with quite a lot of what about SC, but we can talk about that. And it's important to be controversial. But the main point of this is there are quite a lot of types of sickle cell disease, and they do vary in severity. And in most populations, SS is the most common, and SC in African populations makes up about 30%. And in general, the complications and the life expectancy, complications are less severe, and the life expectancy is longer. But I guess in the context of this brief talk, the main point is there are different types of sickle cell disease, about 15 different genotypes. The one thing they all have in common is the hemoglobin S mutation, which is the same mutation in every patient. It used to be codon 6, now it's codon 7 because we count the first ATG. And obviously, the people can be either homozygous or compound heterozygous for this. And the other obligatory slide in every talk on sickle cell disease is a picture of the pointy sickle cells, which this is. I guess the point of this is that although and I'll go on to it, there's a lot of abnormalities in sickle cell disease, and sometimes when you listen to talks, you sort of lose sight of the fact that although there's lots of weird things go on, all the diseases manifest through the red cell, that beta globin is only expressed in the red cell, and all the complications and the secondary organ damage and the inflammation, those are mediated by red cell abnormalities, not by other processes. In most talks, you see lots of people have versions of this slide, really, where you have lots of boxes with complications and arrows going around. Mine is quite hierarchical. I'm quite a fundamentalist believer in hemoglobin polymerization is the source of all evil, and that the other things are downstream epiphenomena. And I think it's pretty much undeniable that without hemoglobin polymerization, none of the other stuff happens. That if you stop polymerization, then you get less inflammation, you get less hypercoagulability. And as I've said, the mutation is expressed in beta globin, which is expressed in the red cell. And the next layer of pathophysiology involves damage to the red cell. When you hear talks on sickle cell disease, everyone has their own kind of favorite little bits and pieces. And there are people who are evangelical about inflammation or about hemolysis, particularly hemolysis. A lot of people will kind of oversell this or that aspect of it, well, not necessarily oversell it, but they have a research interest in it and they emphasize that. But my personal fundamental belief is that red cell dehydration is very important. It's one of the early steps in the pathway, and as I'll come on to it, it's responsible for the red cell dehydration and the increased concentration of hemoglobin S, which leads to the increased tendency to polymerization. The other stuff that I've put in green, I'll talk briefly about, but these are undeniably all sort of downstream phenomena, and although it may be of therapeutic benefit to inhibit one or other of these, it's clearly not as effective as inhibiting hemoglobin S polymerization itself. So again, to cut a long story short, if you stop polymerization, you don't need to worry about all the other stuff. It doesn't happen. So polymerization, as I've said already about 5 times, all pathological consequences flow from the polymerization of hemoglobin S to form fibers. The S polymerization was studied quite a lot, and there's quite a lot known about it, but probably the important thing is that there's a lag phase. It doesn't happen on deoxygenation, which only the deoxygenation forms polymers, but on deoxygenation there's a delay between that happening and the polymers forming, and the length of that lag phase is critically dependent in the sense that if the red cell can get through the capillary and out into oxygenated blood or big blood vessels before it gets polymerized, then the cell kind of survives and goes on to circulate again. Whereas if it becomes rigid and sickled whilst in a small blood vessel or deoxygenated vessel, then it blocks that vessel and you get pathological consequences. The lag phase depends on various things, but in particular it depends on the concentration of hemoglobin S to a very high power, to the 30th power. And the concentration of hemoglobin S is really primarily, some of it's inherited depending on alpha thalassemia, but the second variation comes from the degree of red cell dehydration. That these are diagrams showing the cation loss pathways in which are active in sickle cell, not active in normal cells. And in brief, you have a proposed pathway P-sickle through which calcium enters and activates the guard-off channel through which potassium and chloride leave. And with those, and there's a net loss of cations and a net loss of water resulting in red cell dehydration. And the consequence of this then is that this is a diagram showing that for a relatively small decrease in hemoglobin S concentration, 8%, you get a big increase in the lag time to polymerization that goes from approximately 0 seconds to more than 5 seconds. And that is probably a physiologically important difference between getting stuck in a little blood vessel and getting out into the nice, healthy, big blood vessels. So polymerization is everything, and these are the sort of downstream other things which are also important. Undoubtedly, they contribute to the pathophysiology, but it is arguable how important they are, and they all correlate with each other because they're all related to the rate of polymerization, and it's not clear if any of these is primary as one is more important than the others. Anemia, I think, again, apart from believing in red cell dehydration, I also believe that anemia is kind of one of the fundamental pathophysiology processes. Lower hemoglobin is associated with a poor prognosis, and there's quite a lot of big studies associating low hemoglobin with increased risk of stroke and abnormal TCD velocities and premature death. Other studies then relate, obviously anemia correlates with nearly all the other things, all the inflammatory markers and all the hemolytic markers correlate closely with anemia, and the question then is whether the anemia is important, or whether in the sort of studies that are done, people relate say inflammatory markers to increased death, and the question is whether that's a causative factor or whether it's just an epiphenomena related to anemia and the related polymerization. As I mentioned, hemolysis is the thing that over the last 15 years now has been sold very heavily as an important fundamental part of pathophysiology, being almost equivalent to vasoocclusion, and that may or may not be true. It's certainly true there is a lot of hemolysis, and there are association studies with pulmonary hypertension, priapism, leg ulcers, and cerebral vascular disease showing that these are associated with higher rates of hemolysis. They're also all associated with higher lower hemoglobin levels, and I think it's arguable how central hemolysis is to pathophysiology. And I'm not talking about treatment in this, but it is true that most, in fact, all of the treatments based on NO therapies have been unsuccessful, which does kind of suggest probably it's not that central to primary pathophysiology. Inflammation, again, is undoubtedly present. You're constantly infarcting little bits of tissue, causing a chronic inflammatory state, and there's a whole list of things which are linked to chronic inflammatory conditions, many of which also occur in sickle cell disease. Again, whether inhibiting inflammation is of therapeutic benefit is a still unanswered question. The blood is also undeniably hypercoagulable, and due to a whole range of things, including activation of the coagulation cascade, low levels of protein CS and antithrombin, there are increased numbers of platelets, and the platelets are activated, there are microparticles, and the blood vessels are damaged. So, and again, as I won't dwell on, but they're possibly by inhibiting at least P-selectin, inhibiting some degree of one of the either hypercoagulable mechanisms, then that appears to have some therapeutic benefit at this stage, suggesting maybe that this is a more important part of the pathology. Patients are often hypoxic, not always, and again that is due for a number of reasons, and that has been linked fairly reliably to two pathological events. One, having increased frequency of pain, acute pain, and an increased risk of neurological events in children. In fact, children, and possibly adults is less clear, but children who have oxygen saturations less than 95%. And then oxidative stress and reperfusion, again, is undoubtedly important that there's a lot of hemoglobin autooxidation and free radicals around, and the tissues are deprived of oxygen and then resupplied with oxygen as the blood is recanalized, and undoubtedly that is very damaging to tissue. Again, it's clearly not a primary event in the sense that if you can inhibit polymerization, it wouldn't happen. But again, a study looking at L-glutamine suggested that reducing oxidative stress is a therapeutic benefit. The thing that comes out, I think, stands out from all this is that there are a lot of all these parallel processes going on, and you'd guess you'd probably need to have an effect. If you don't inhibit polymerization, you probably need a multi-drug approach to it. You need to inhibit coagulation, inhibit inflammation, reduce oxidative stress, correct anemia, and all those things together may be enough to equate to reducing polymerization. We've already had hemoglobin SC mentioned. I said it is fundamentally a different type of sickle cell disease. I say we do different things to what they do in Germany. We do give all the children penicillin V from 2 years of age. And I think there's a lot to be known about hemoglobin SC disease. It's different. I think the pathophysiology is fundamentally different. They have only 48% hemoglobin S in the red cells. And the primary problem seems to be that the hemoglobin C causes dehydration. There's similar processes occur in other types of sickle cell disease. It's a kind of very much a neglected part of sickle cell disease. It's very common in African populations, and most of the patient information that we give out and that most people give out, in fact, is for generic sickle cell disease and applies very much for SS, but in fact ignores the fact that the natural history and the complications of SC, as Dr. Haber said, are actually very different, and that most things are less severe, but some things are more severe. So in summary, hemoglobin S polymerization is the initiator of all pathology in sickle cell disease. I'm being very didactic actually, all complications are mediated by the abnormal red cell. I think those things, although you rarely use all or never in medicine, I think both those statements are true, I think. Vaso-occlusion is the main pathological process. That's arguable, but I believe it. And then there's a cascade of interrelated pathological events which follow on from the S polymerization, but it's unclear which of those are most important. They're all important in one sense, and they're all not important in another sense. And it is a chronic illness with acute exacerbations. Thank you.